Hello, my name is Dr. Linden Karas, and I am the director of Avita's new Center for Bariatric Surgery. I'm also the bariatric surgeon here. Thank you for joining me today to learn more about obesity and the treatment of obesity and its related diseases with bariatric surgery. Today, we'll talk a little bit about the science behind obesity. We'll discuss who is a candidate for bariatric surgery. I'll tell you why surgery is a safe, effective, and durable choice. I'll describe the different medical, endoscopic, and surgical options offered at the Avita Center for Bariatric Surgery. We'll talk a little bit about the preoperative education required before surgery and how our team will follow you for life after surgery. Obesity is defined as an abnormal or excessive body fat accumulation. It is identified by a body mass index, or BMI, of 30 or higher. BMI is a standardized formula that compares height to weight and is internationally recognized as a method of classifying overweight and obesity. You're not alone. More than a third of adults in America are obese. In this diagram, you can get a feel for the classification of overweight and obesity. If you use a 5-foot, 4-inch woman as an example, at about 130 pounds, her BMI would be calculated at 22, and this puts her in a normal weight range. If she gains just 20 pounds, her BMI becomes 26, and she's classified as overweight. Add another 20 pounds, and her BMI is 30, classifying her as a class 1 obese person. And add 30 pounds to that, and she has a BMI of 35. Making her morbidly obese and a candidate for bariatric surgery. You can use this table to compare your height and weight and calculate your own BMI. Alternately, you can go online and use a BMI calculator. Now that we've learned about the classification of overweight and obesity, let's talk a little bit about the science. There is more to obesity than overeating and not exercising. Genetic factors and the environment also work against us. Body weight and fat levels are regulated by a complex system of signals in the body. These signals control appetite, digestion, energy balance, and metabolism to keep your body and fat at a steady level or set point. For many people, once they gain weight, this set point goes up, making it very difficult to lose weight or keep weight off. After losing weight with diet and exercise, a starvation-type defense mechanism is activated that attempts to return them to their original higher weight or set point. This leads to the regain of much of their hard-earned lost weight. After diet and exercise-induced weight loss, hormone levels change, signaling your body to increase its appetite and decrease its metabolism so that you regain the weight that you've lost. This is why it's so hard to lose weight and keep it off with diet and exercise alone. In fact, studies have shown that 95% of obese people who lose weight with a rigorous weight loss program gain all the weight or more back within 2 to 5 years. But obesity is not only carrying extra weight or body fat. Many diseases go hand in hand with obesity, and these diseases affect nearly every organ system in the body. In this diagram, you'll see how many organ systems are touched by obesity. You'll recognize some familiar diseases like obstructive sleep apnea, high cholesterol, high blood pressure, heartburn, diabetes, and degenerative joint disease affecting the knees and hips. Obesity is also clearly linked with an increased risk of many cancers, including breast, colon and rectum, endometrium, esophagus, kidney, and pancreas. Obesity and obesity-related medical conditions increase the risk of early death. Starting at a BMI of 25 to 27.5, the classification of overweight, mortality risk is increased by 7%. And for every 5 units you increase your BMI, you increase your risk of early death by 31%. Now that we've learned about the science behind obesity and why it's so difficult to tackle with lifestyle modifications alone, I'll explain to you the services offered at the Avita Center for Bariatric Surgery. We offer medical, endoscopic, and surgical weight loss procedures, depending on your classification of overweight and obesity. In order to participate in any of these programs, you'll have to have attempted and failed multiple diet and exercise plans. You become a candidate for surgery if your BMI is 40 or greater, or if it's 35 or greater and associated with an obesity-related medical condition. Typically, in the overweight category of BMI of 25 to 30, we recommend aggressive lifestyle modifications. Our bariatric exercise program and team of dietitians will help you to design a tailor-made program of aggressive lifestyle modification. When your BMI reaches 30 to 35 with an obesity-related medical disease, or 35 to 40 without one, we add medication therapy to this lifestyle modification plan. Finally, when your BMI reaches 35 with an obesity-related comorbidity, or 40 without one, you become a candidate for bariatric surgery. So why choose surgery? Because it's safe, it's effective, and it's durable. The complication rate for bariatric surgery is lower than for other common procedures, including removing your gallbladder, a hip replacement, or open heart surgery. And while there are risks with any surgery, advances in bariatric surgery over the years, and the fact that almost all are performed laparoscopically, have reduced the incidence of serious events and death. The risk of death from bariatric surgery is less than 0.5%. Complications occur in less than 5% of patients. And laparoscopic procedures lead to shorter hospitalizations, less wound complications, and less pain after surgery. The most serious complications include staple line leaks and bleeding. These occur in only 1 to 3% of patients. You can anticipate 100 pounds or more of weight loss following bariatric surgery. And surgery helps to improve or resolve more than 40 obesity-related medical conditions. Studies show that surgery reduces a person's risk of premature death by up to 40%. Diseases such as diabetes, hypertension, sleep apnea, and high cholesterol can be improved or resolved in upwards of 76% of patients. There's a 60% reduction in mortality due to cancer, and a 56% reduction in mortality due to heart disease. And the improvement and resolution of these medical conditions, as well as weight loss, is durable. Studies have shown that improvements in these medical conditions and weight loss extend for 5 years or more. At Avita, we offer medical weight loss, endoscopic weight loss procedures, and several surgical options. All of these surgical procedures are done laparoscopically with a camera and mini incisions. The Roux-en-Y gastric bypass is the gold standard of bariatric surgery. We've been doing this procedure for more than 30 years. In a gastric bypass, the top portion of the stomach is stapled off into a small pouch. The rest of the stomach and the first 80 inches or so of the small intestine is bypassed, and we bring a lower portion of intestine up and attach it to this small gastric pouch. This limits how much you can eat and decreases how much you absorb of the foods that you do eat. Please pay close attention to this video provided by our colleagues at Ethicon Endosurgery that explains the process of a gastric bypass.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a gastric bypass, a small pouch is created in the stomach using a stapling device. The small stomach pouch, about the size of an egg, limits the amount of food you can eat before feeling full. The small bowel is separated into 2 sections. The lower portion of the small bowel is attached to the newly created stomach pouch. This allows food to pass directly into the second portion of small bowel, where digestion continues. The upper portion of the small bowel is reconnected to the lower. Bile and pancreatic fluids from the liver and pancreas allow food to be digested completely. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals.
The sleeve gastrectomy is currently the most popular procedure in the United States. We take a stapler and remove 75% of the stomach. This excised portion of the stomach is removed completely from the abdominal cavity. You're left with a banana-sized and shaped stomach, which drastically decreases how much you can eat. There is no reorientation of intestine with this procedure. Please pay close attention to this video from our colleagues at Ethicon Endosurgery describing a sleeve gastrectomy.
To access the abdominal cavity, small incisions are created. Trocars are placed to serve as passageways for surgical instruments. The surgeon examines the abdomen using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is combined with digestive enzymes. These help break the food down into a simpler form so that it can be digested more easily and absorbed in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters and is about the size of a banana. The resected portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. Bile and pancreatic fluid from the liver and pancreas mix with food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or postoperative adjustments needed for the sleeve gastrectomy.
At Avita, we also offer a procedure called the duodenal switch. This procedure is typically reserved for patients with a BMI of greater than 60 or classified as supermorbidly obese. This is a combination procedure where we first create a sleeve gastrectomy out of your stomach, and then we do a very aggressive intestinal bypass procedure, leaving you with a very short amount of intestine through which your food will pass. Adjustable gastric banding consists of the insertion of a synthetic plastic tube around the top portion of your stomach. This decreases the amount of food that you can eat. This banding can be tightened or loosened by injecting or removing saline into a small port that is placed underneath your skin on your abdominal wall. At Avita, we also offer revisional surgeries. Occasionally, after bariatric surgery, patients experience inadequate weight loss, weight regain, or complications. In these scenarios, we can help. We can remove adjustable gastric bands. We convert adjustable gastric banding, sleeve gastrectomy, and vertical banded gastroplasty into a Roux-en-Y gastric bypass. We can convert a sleeve gastrectomy into a duodenal switch, and we can revise gastric bypass for weight regain or complications. We also offer the endoscopic placement of gastric balloons. With this procedure, 1 or 2 saline or air-filled balloons are inserted into your stomach. This is not done surgically, and there are no cuts made on the abdomen. Instead, under sedation, an endoscope is placed into the stomach and the balloons are deployed. This procedure is temporary, and the balloons must be removed after 6 months. Also, this procedure is not yet covered by American insurance companies, and therefore is an out-of-pocket charge. In talking with friends or family about the bariatric surgery process, you might have learned that a lot goes into getting ready for surgery. Some requirements are based on the program, and some are based on American insurance companies. Mandatory diet and nutrition education is required by both insurance and the Avita program. American insurance companies often require between 3 and 9 months of supervised weight loss attempts. These must be consecutive monthly appointments with the dietitian or your primary care provider that document your diet and exercise attempts to lose weight. Your primary care provider and other specialists will need to provide medical optimization and clearance before we can perform surgery. A behavioral health evaluation is also necessary to ensure that you can cope with the major lifestyle changes that are coming your way after surgery. I'll perform an upper endoscopy to ensure that there's no inflammation or any other abnormalities of your stomach that would change the type of procedure we're planning to perform. If you've never been diagnosed with sleep apnea and are at high risk, you'll undergo a sleep study and be fitted with a CPAP. Routine lab work, chest X-ray, and EKG are performed on all patients. Any vitamin deficiencies that are detected will be corrected prior to surgery. Finally, the AVITA program requires attendance at least one support group or 2 sessions of our bariatric exercise class prior to surgery. After surgery, you can expect to spend 1 to 2 nights in the hospital. On the night of surgery, you'll be able to walk around and drink liquids. In fact, your only job for the first 2 weeks after surgery is to walk and to drink. Most people return to work between 2 and 4 weeks after surgery. The only restrictions that you'll have following surgery are the slow advancement of your diet from liquids to solids over the course of 4 to 6 weeks following surgery, and that you can't lift anything heavier than 10 pounds or a gallon of milk for about a month after surgery. You'll become good friends with our team at the Center for Bariatric Surgery while preparing for surgery, and you'll never forget us during a lifetime of follow-up. You'll see members of our team many times throughout the first year after surgery, and then annually thereafter. As a surgeon, I'll take care of the technical aspects, but I couldn't do this job without our team at the Center for Bariatric Surgery. Our bariatric coordinator is your go-to person with questions or concerns throughout the preoperative and postoperative process. Our dietitians at Bucyrus and Ontario hospitals will help get you ready for surgery and keep you on track afterwards. Our psychologist, Dr. Erin Becker, will perform behavioral health evaluations. Of course, none of this would be possible without the AVITA family of care providers who've been taking care of you for so long and will help ensure that getting you through surgery is safe and effective. So what's next? Please fill out the online questionnaire with as much information as possible. Soon, our office will contact you and begin scheduling you to see myself, the dietitians, psychologist, and all other necessary appointments in your workup for surgery. At any time, you can call our office with questions, concerns, or for more information. Thank you so much for joining me today, and I hope to see you in the clinic soon.